and that is what is an AbCO2R. Until now we keep on discussing about the gas exchanges, both oxygenation as well as the ventilation aspect. What I am going to concentrate is only every time you don't get both the things. Oxygenation and ventilation both may not be the problem every time. So if you have only a ventilation as a problem and not the oxygenation, then you can come out with a smaller device and an easier method. And that is what is a carbon dioxide removal devices. Okay. There are basically two types. One is an AbCO2R, the second is an ecco2R. AbCO2 is an arteriovenous carbon dioxide removal, and ecco2R is an extracorporeal carbon dioxide removal. The difference between these two is in AbCO2R we are using a artery as a pump. So artery acts as a pump, it pulls the blood out, blood goes to the oxygenator and it comes back to the veins. And that's the way the carbon dioxide is removed. While in ecco2R you are using again both the veins and you have to use a pump for because we are using both the veins, we are covering the artery canals. So in this your ventilation is taken care of with the device, while your oxygenation is going to be taken care with the help of native lungs. So AbCO2R is a carbon dioxide removal, okay, and it's a low resistance gas exchanger in a simple arteriovenous shunt, and that's the reason you can use it as a AbCO2R. The resistance of the gas exchanger is very less. If you have more resistance, you have to apply more force for the blood to pass through that. Okay. So here there are two advantages. One is the gas exchanger is has got very low resistance, and the second time the amount of blood which you require to flow through this is going to be very, very less. That's the amount of blood which you require in ecmo. CO2 is removed and oxygen transfer are uncoupled. CO2 is transferred across the membrane gas exchanger, while low frequency ventilation, oxygen diffuses across the native lung. So you can go on high pressure, you can go on high peak, you can come down on the respiratory rate, you can come down the even tidal volume also, but that will take care of your oxygenation. You can improve the oxygenation by that through the ventilator. Only worry that when you come down on low tidal volume and low or minute ventilations, you are always worried is CO2 going up. So you can uncouple both the things. Let the ventilator take care of the oxygenation aspect, and let the carbon dioxide removal can be taken care with the help of AbCO2R. This way the things have been done. It's an arterial and venous cannula. Basically it goes through the oxygenator and it comes back and returning back. Okay, this is the way it has been done. This is the gas exchanger, and it's going to be very low resistance gas exchanger. Advantage, it's a low resistance membrane, so cannula size is going to be small because you require less flow, you require there is less resistance, so cannula size is going to come down as a small. Heparin requirement is going to be less because you are going to have less flow and less resistance, so heparin requirement is going to be less. You don't target SCT around 180 to 200, you target SCT around 140, 150, that's okay. Less flow to remove the carbon dioxide, does not require any pump, okay, for AbCO2R, and small circuit length, and that's the reason the complications of whatever the extra circuit length is going to be less. Okay. So these are the advantage of using this. Anybody can tell me why less flow is required to remove carbon dioxide?
Faster diffusion.
Yeah, it doesn't depend. The gas exchange what we discussed is carbon dioxide is usually a gas variable and oxygen is the blood flow variable. So it doesn't require carbon dioxide for you don't require a higher flow to remove the carbon dioxide. If less flow is there, that should be enough. What you require is more of sweep gas flow to remove that much of carbon dioxide. Obviously, this science can only take care of the carbon dioxide. In a run, you find oxygen is again giving a problem, then you switch over to. Indications in case of COPD, where carbon dioxide is going to be a problem, you can think of it. In case of status asthmaticus, again, we are not able to ventilate again. Probably the oxygen is not going to be a great problem. Carbon dioxide retention is a problem. You can think of using this. In lung injury with the CO2, that remains as a major concern. In some ARDS, you are able to ventilate at a low cardiac volume, low minute ventilation, high PEEP. But the problem was when the CO2 goes up. In that case, you can uncouple both the things and use AbCO2R. And when there is a step-down therapy for ecmo, when the patient is on ecmo for few days, he is doing well, he is maintaining oxygenation, but the carbon dioxide levels are going up, then in that case you should always you can come down from the ecmo and put them on ECU. Now there are few studies made on initial studies were made on sleep, and they found out that there is going to be an effective range of which is the cannula size is required is going to be low. There are some human studies, 5 out of 5 completed 72 hours trials, 3 after the final discharge to had some minor complications. That was published in this, and then 8 out of 8 is completed 72 hours trials of ARDS with hyperthermia, 5 of them survived. This is what I told you, this is the way it will be like this. This is the novel one, it's containing gas and mold, so these are size of the artery, small size of the artery. Usually, for an adult person, usually your 13 to 15 French cannula is going to be enough. Instead of about 27 French cannula or 19 French cannula of arterial, this cannula is going to be a smaller size cannula, gas section is going to be taken as here. But see the safe gas flow. If you require almost 110 liters per meter safe gas flow, to go sort of come. It's going to be low resistance, so the aerobic sensor will be not going to be resistant.
But it has to have, the patient has to be hemodynamic stable.
Yeah. If the hemodynamic is not stable, then you cannot put on any CO2 axis. Because the artery vessel is not there, there is going to be a pump for your artery is going to be a pump for the entire drive. If it's, then you have to think of putting on ECCU part. These are the vessels, they have tried around 100 vessels, and out of that the sepsis 17%, so the 12% was sepsis, trauma, and pneumonia, and the results is 40% for the vessels with some other indications, 65% because of sepsis, 80% incidental. This is the transport exchange, the gas exchange, is what we got this device more. These are studies that we more on smoke of 1 to 3 patients who have been put on ventilator. They are more of they have tried with the ECO2 and some of them have tried on low diagonal ventilation, and some of them have tried on the high frequency ventilation. There was significant improvement in the ECO2 compared to low diagonal ventilation. ECO2 has normal carbon dioxide and pH and decreased in ventilation bowl. Less MPO is present with 72 hours of post-criteria of ECO2 and lung neutrophils at 72 hours of post-criteria. Nature of the graph found to be apoplectic to either educate. So they found to be less harmful. So the less, because the circuit side test is not going to be much of a problem. Carbon dioxide plus which is reacted by ECO2 may be reported in open tissue neutrophil apoptosis, results in inflammation maintaining normal reliability. The reduction in complications rate also are there. See the stain of the lower endocrine artery. So estimate of bleeding is going to be only for if you are using your regular ecmo and BA ecmo, the estimate is going to be more. These are compared to trials, the complication rate reduction is coming down. The cannula size is also smaller. So it improves survival. More than 50% they were not taken and they found it to be hospital is only 35%. This is the novel and registered trial. 38 cases were reported. Negative precipitation, unfortunately, for the first cases in centers, and more cases in surrounding institutions. And the early use of this might frequently improve the this is what before the novel therapy and under the novel therapy, we see the requirements come down, the mean admission program, the beat they can go up on the beat when they put on the novel, the respiratory rate which was almost 26, they have come down to 11 because the CO2 is removed done by the machine device. The main maintenance from 11 has come down to 4. the peak resistance decrease, the carbon can come down, pH improve, the CO2 level improve, the CO2 level is not the Toronto, there are different trials which have been done and they have found that this would be useful. So those patients who are having still the lungs are not recovering or they are for either lung transplant or lung recovery, they have something like paracorporeal artificial lung device. Basically, it works on the principles of flow rate and they take care of the CO2 removal. The right ventricle assist you as kind of that. Most of the cardiac output goes to the paracorporeal nervous and is able to remove the carbon dioxide. They are coming down with minimally invasive double limit cannulas so that they can avoid tracheotomy and that. The devices. So it is not yet fully established, fully market, but that is what they have been planning to do it so that the life can become immediately with this device and by the time the lungs recover, so they require maintenance.